Okay, so this PowerPoint goes along with the chapter in your book on diagnoses commonly associated with childhood. Let's start by talking about some chromosomal abnormalities. There are structural chromosomal abnormalities. There are deletions, translocations, which means that a part of a gene is deleted or a part of a gene is translocated, moved somewhere else. For example, cri du chat, cry of the cat, is an example of one of those. There are numerical abnormalities, Klinefelters, which is XXY. There's trisomies, typically of 21, 18, or 13. And Down syndrome, as we know, is trisomy 21. They result in many different disabilities. Some are not easy to survive. Sometimes there'll be a spontaneous abortion with some of these. Some of these are quite survivable, but they go along with intellectual disabilities and other sorts of abnormalities with heart, lungs, kidneys, all sorts of other things. So most of these genetic abnormalities can be anywhere from mild to severe and involve some sort of intellectual impairment, although not always. Some syndromes and conditions that we need to understand that you'll be looking up when we get to class. You'll be looking up some of these, but just for a brief, fetal alcohol syndrome and fetal alcohol effects is a completely preventable disability, developmental disability that occurs when the mother drinks while pregnant with the fetus. And those things include behavioral difficulties, learning disabilities, intellectual disabilities, sometimes motor disabilities. Prader-Willi, DiGeorge also involve intellectual disabilities and physical disabilities. DiGeorge in particular has heart issues that go with it. Fragile X is a series of disorders from a broken piece or a piece that can break of the X chromosome. And is more pronounced in males than females because they only have one X. Williams-Elfin-Facey is significant intellectual disabilities as well as physical issues, malformations. Neurofibromatosis is one that causes benign tumors to grow on the nerves, which are essentially everywhere. And that can be anywhere from in the nerves in your eye and in your brain to in your gut to on your skin. That's also sometimes referred to as elephant man syndrome. Some neuromuscular disorders that you might run into are muscular dystrophy, which there are several different categories of muscular dystrophy, Duchenne's being the one where children very young are affected. They're living longer and longer at this point, but it does shorten the lifespan. Spinal muscular atrophy is another neuromuscular disorder similar to muscular dystrophy, but a different part is affected, a different part of the nerve pathway is affected. In both spinal muscular atrophy, also known as SMA, and muscular dystrophy, the muscles don't continue to grow and thrive. In muscular dystrophy, the muscles are replaced with fat tissue, and in spinal muscular atrophy, they waste. Limb-girdle muscular dystrophy and myotonic muscular dystrophy are other forms of muscular dystrophy other than Duchenne's, and they look a little different, and limb-girdle is mostly associated with the upper extremities. Cerebral palsy is a brain disorder. Cerebral palsy is when there is some sort of insult to the brain that affects motor function. Then some disabilities can be as a result of a central nervous system infection. So one of the big ones that we see is a central nervous system CMV infection. So CMV is cytomegalovirus, and it's everywhere. It's endemic. Probably I've been exposed to it. I don't even know how many times. Many people get it. And if you get it, as a healthy adult, you get a mild case of the flu or a bad cold and you're done. The only time it causes a problem is when there is a primary infection. So when a mother gets infected for the first time that she's ever been infected with CMV when she is pregnant. And that causes many, many developmental disabilities. And the child who is born affected by CMV will shed the virus in their saliva and urine for the rest of their lives. So if you have a child that has CMV, you don't want anybody who is a woman in childbearing years to work with that child because they can catch CMV from the baby or the young child. So we want to make sure that that's one of those things that we know about when we pick up a child if they have CMV, and we want to be extremely careful if you are of childbearing years that you don't work with a child like that. Infections that happen during birth, HIV and STDs can cause blindness. They can cause all sorts of other issues if the mother has an active infection during birth. A lot of times what happens if a mother has an STD or AIDS, HIV, they will do a C-section so the baby does not get exposed during birth. After birth, CNS infection is meningitis. Some children get meningitis very soon after they are born, causing complete recovery is possible, but a lot of times there are some ongoing disabilities that occur from the meningitis, which is a swelling of the meninges, which are some of the tissues that surround the spinal cord and brain, and meningitis is a swelling of those tissues because of a viral infection or bacterial, either one. The bacterial infection of meningitis is much more deadly than the viral. Hearing and visual impairments, these can, again, be mild to severe, and they affect one or many areas of development. A child that has a visual or hearing impairment, depending on how severe it is, can affect gross motor skills, fine motor skills, self-help skills, the whole gamut, everything, or nothing. There are some psychiatric conditions and social emotional disorders associated with childhood. Attachment disorders is how well a child attaches to their primary caregiver. They can have a diagnosed emotional disability. Post-traumatic stress, which in children often comes from things like physical or sexual abuse or having witnessed such abuse. Children can have classic post-traumatic stress disorder. General behavior disorders, and a lot of times what we find in early intervention in particular, which is the birth to 3 range of things, these children just do not have a diagnosis yet. We just know that they are not following along the developmental path that they should be on. They are not increasing and gaining skill every week as they mature. We just have a description of what's not going on. We don't necessarily have a name for whatever. A couple other things you might run into when you're working with children with disabilities. LBW is low birth weight. That means that for the gestational age of the child, they didn't weigh enough. And SGA is small for gestational age. That's an overall length, usually size. So you can either have low birth weight for your gestational age or just be overall small. And a preemie is generally defined as any infant with a gestational age of less than 33 weeks, 38 to 40 being typical. Cerebral palsy is brain damage that causes motor disability, so it's damage to the motor cortex from a variety of different sources. You can have cerebral palsy from an in utero issue or event. You can have a malformation of the brain. You can have an infection or a stroke. A stroke, CVA, can happen in utero, and it would either be hemorrhagic or ischemic. And we've talked about those terms before. Hemorrhagic being a stroke because of too much blood, a bleed in an area of the brain, or ischemic, which means a lack of blood supply, usually caused by a blood clot. At birth, an infant can be hypoxic or lack oxygen at birth. That can especially happen if the baby is stuck in the birth canal and doesn't proceed through the birth process in an expedient way. That can also happen if the cord is around the baby's neck or if the cord is crimped somehow, some other structural abnormalities. At birth, The largest risk to preemies at birth is a brain bleed, so a stroke, a hemorrhagic stroke. That is the largest risk for preemies. They just tend to have a lot of brain bleeds, and which can cause a stroke after that at birth. Also at birth, babies can be infected with meningitis. They also can get pneumonia at birth, which can sometimes have side effects of anoxia or hypoxia. At birth, there are also accidents that happen, traumatic brain injuries and accidents after birth that can cause cerebral palsy or infections. Accidents also such as shaken baby syndrome, falls, anything like that can cause a car accident, anything like that can cause a TBI. So cerebral palsy is divided differently in different texts. So it's good to know how it's divided and what those terms mean. Spastic cerebral palsy is hypertonic, means too much muscle tone, too tight. Dystonia is hypertonic with spasms, and athetoid is very poorly controlled movements. So if you went to reach for a glass of water, you might shoot your arm out really past it and then try to pull back and end up knocking it over. Athetosis looks like very poor control. Hypotonia is low muscle tone or floppiness in young children. So they would be just so floppy they wouldn't be able to hold their head up, hold their body up in sitting, anything like that. So cerebral palsy can be divided into categories of tone, or it can be divided into what body part is affected. So diplegia, di being two, means legs are affected. Diplegia always means legs, it never means arms. So it just does. So diplegia means that the baby's legs are affected with whatever kind of tone is in the top. Hemiplegia means one side of the body, either the right or the left arm and leg. Quadriplegia means both arms and both legs are involved. So hypertonia, some things to know about muscle tone. Muscle tone is a central nervous system thing, and it doesn't really express itself until 12 to 18 months of age. So if you see a baby straight out of the NICU that had a incident at birth, say for example they had a brain bleed right after birth, or during birth they had a lack of oxygen, hypoxic moment, and there's a suspicion that this child could have cerebral palsy, the doctors will tell the parent, we think this child could have difficulty crawling and walking because of the anoxic moment they had, or the fall they had, or the infection, or whatever it was. You're not really going to see it at first. High muscle tone takes time to develop. They often start with very low head and neck tone, so they start as kids who can't hold up their head when expected at about 3 months. They start out as kids who just feel floppy. They maybe don't have that nice physiologic flexion that we talked about, which is typical of newborns. Or they could look fine. They could have just fine physiologic flexion and just fine head and neck tone, and then develop the spasticity later on. Typically, they start with low head and neck tone and develop high tone in the arms and legs later, but not always. Each kid writes their own book on how to do this. Hypotonia is floppy, no areas of increased tone, and this you will note right from birth. The baby will be floppy right from birth. When you put the baby down, they will kind of melt into the surface. Their arms will go out, their legs will go out, and they'll be down on the surface. There won't be any of that nice physiologic flexion. Athetosis also doesn't always show up right away, but it can, and that's that fluctuating and poor mid-range control. So there are a lot of other things that happen when kids have cerebral palsy that it's important to know about. One is they can often have hearing and vision issues, so you want to make sure that those are diagnosed, and whatever vision or hearing aids the child needs, they get. The sooner they have typical hearing and vision, the better their development will be. About a third of the kids have some sort of a seizure disorder, and that's because the cerebral palsy is damage to the brain. So any damage to the brain, you're at higher risk for seizure disorder. These kiddos may have an intellectual disability or may not. And it's very important to assess whether or not you think they do. A child who has a lot of motor disabilities from having cerebral palsy, but has typical or above typical cognitive skills, you have got to stimulate those cognitive skills as soon as possible, or indeed you will lose them, or the child will lose them. So they need to be intellectually stimulated, and so you have to figure out as best you can where their cognitive abilities are at. Then the other issue they often have is speech delays, because the muscle tone that is either too high or too low, it's central nervous system tone, and so tone is tone is tone. So if you have high tone in your legs, you could very likely have high tone in your tongue and lips and cheeks, so that it's hard to make sounds. If you have low tone in your body, you also probably have low tone in your face and in your tongue and lips, and so you're probably drooling a lot, and you probably are having trouble making sounds accurately. So those things all overlap. Some of the other things that we might see when a child has cerebral palsy are perceptual difficulties. So the way children learn things like on, under, through, over, the way they learn those perceptual concepts is by doing them. They learn under by getting stuck under the couch, and somebody says, "Hey, Bobby, what are you doing under the couch?" And they learn things like on by doing the boogie woogie on the kitchen table, and their mom comes in and says, "What are you doing on the table? Get off now." And that's how they learn on and off and the other concepts. But children with cerebral palsy, they don't do those things. They don't climb onto the table. They don't get stuck under the couch because they don't move. They don't have typical movement patterns. So they tend to have a lot of visual perceptual issues because they just never learned these things in their bodies. So they have a hard time conceptualizing of them and learning them abstractly. Children with cerebral palsy often are premature, and so they have any sort of health conditions that relate to being premature. So that includes things like retinopathy of prematurity, which is a visual issue with the retina. That includes breathing issues and lung function, which is also a consequence of prematurity. That includes anything else that, the other big one is constipation. Preemies tend to be very constipated and have poor digestive motility. So they're likely to have health problems due to the prematurity, like any other premature baby would have. Kids with cerebral palsy also can have feeding issues, which can lead to failure to thrive or not. But they most definitely are going to have some difficulty early on. If a child has either low or high muscle tone, they're going to have trouble nursing, and they're going to need some special assistance with that. Some kids with high tone, I just give up and I don't even bother with the bottle. I just use an eyedropper or a spoon to feed them their liquids because they're not going to be able to get that nice closure around the nipple that they need in order to feed properly. And it actually is not a skill that you need again. When we do the feeding PowerPoint, you'll see that you don't really need that skill ever again. So it's not necessary to teach it once a child is past the age of using a bottle. I mentioned the constipation. GERD is gastroesophageal reflux disease. That's a lot of our kids with cerebral palsy have GERD, and that causes pain and discomfort in the esophagus. It causes pain and discomfort after eating or drinking. And so it leads to feeding issues and behavior issues and food aversions. And again, they're chronic lung issues with a lot of preemies have. Kids with cerebral palsy have difficulty engaging with others because of their motor deficits often, not always, but often. And they are often more surrounded by adults, by therapists and teachers and people like that. So they learn to interact socially with adults before they learn to interact with children. And this can sometimes cause some social emotional distress and difficulty with engaging with other children. So we need to be aware of that. Because kids with cerebral palsy do not stand necessarily, and if they do stand, they might not stand as much or for as long. They might not be able to walk as long or as well. They're at higher risk for osteoporosis and growth retardation. They tend to grow very slowly and be little because the growth plates are on the ends of the bones, and the way the growth plates are stimulated is by proprioception, or the pushing together of the two ends of the bones, long bones. And if those long bones don't receive that end-to-end stimulation, then the growth plates are not activated, and the kids remain really tiny, and they also are at high risk for osteoporosis and the fractures that result from that. That is one of the reasons that when we have kids with cerebral palsy, we put them in standing frames and in standers. We have prone standers and supine standers and all sorts of ways of getting these kids up. One of the reasons is to help with growth. The other one is to help with osteoporosis. And then the third reason to get them up is to help with digestion. So for many reasons, it's a really good idea to get these kids up and vertical. They tend to drool from either high or low muscle tone. That just is. So that's a good thing to work on. They tend to be late with toilet training, if at all. So many kids with cerebral palsy do not end up becoming toilet trained. Depending on how severe their symptoms are, they may or may not be able to be independent in the bathroom. Our kiddos with cerebral palsy that have hemiparesis, that have one side affected, are at very high risk for lung collapse because they get scoliosis. So they're at high risk for both scoliosis and lung collapse. And whether the scoliosis is functional or fixed, they're still at high risk for that. And they have other various orthopedic issues, including contractures. A contracture is a permanent shortening of the muscle. So if a joint is held in a particular position and it is never extended to its fullest, the muscle will eventually shorten permanently into what's called a contracture. The only way to fix those is surgically. You can't fix them with braces or splints or anything like that. So here are some of the medical treatments for spasticity for high muscle tone. Botox, believe it or not, is not just good for wrinkles, it's good for spasticity. So botulinum toxin is injected into the muscle belly, and what Botox does for your face, when people want to use it for wrinkles, excuse me, is that it relaxes the muscles in your face. It paralyzes them essentially so that they don't cause wrinkles. Botulinum toxin does the same thing for spasticity. It relaxes and paralyzes some of the muscles when injected directly into the muscle. Again, it has to be done by somebody who knows what they're doing because you could cause a lot of problems. So children that have botulinum injections do it sometimes as a precursor to see if surgery is a good idea. So if we are to cut the innervation to this muscle, would we then be able to function well? So they'll do botulinum toxin to see what happens. But you have to be careful with it because anybody that gets botulinum toxin has to have regular blood levels done to make sure that it is not getting out into the bloodstream, because it is deadly if it gets into the bloodstream. The other thing that is used for spasticity intervention is intrathecal baclofen. Baclofen is a drug. It's a muscle relaxant. Intrathecal means that they put it directly into the spinal column. There's a little port or a little device, a plastic device that has a catheter directly inserted into the spinal cord. And on the outside, there's a little place where you can add the medicine, a little plastic reservoir. And that way, when they do it intrathecally, they find that it doesn't make the child all loopy, like with a muscle relaxant. I don't know if any of you have ever had one, but muscle relaxant makes you kind of loopy and tired, and it's a sedative effect. But when they do it intrathecally, it does not have a sedative effect. It just relaxes the muscles. So that's a very good idea for controlling spasticity. Excuse me. The other one is selective dorsal rhizotomy. That's a surgical procedure that cuts the nerve roots at the spinal cord that go to the muscles that are overactive and spastic. Some of the other surgical interventions are a Z-plasty, where they take the muscle and if you draw a Z in it and then you shift one piece of the muscle down on the Z, they're still attached, but it has lengthened the muscle. And also there's surgeries to correct scoliosis. So these are diagnoses that are likely to result in developmental disabilities. So blood levels, elevated blood levels can lead to behavioral difficulties, learning disabilities, intellectual disabilities, things like that. Failure to thrive is what FTT is. And children with failure to thrive, the brain doesn't get enough food. So the brain has to get food just like the rest of the body, and otherwise it doesn't grow. So they're at risk for cognitive dysfunction, HIV infection, vision, cognitive dysfunction, and child abuse or maltreatment, certainly social emotional, in addition to physical delays. The next set of disorders we're going to look at are some other developmental issues that can happen. Feeding disorders, we're going to spend a lot of time in a few weeks going over feeding disorders and what they look like, where they come from, and how to address them. Feeding disorders are very important, obviously, in the pediatric population. Children are growing very quickly, and in order to grow, they need good nutrition and they need good sleep. Sleep disorders can disrupt an entire household, a sleep disorder in a child, and can result in the other children not getting enough sleep, certainly in the adults in the household not getting enough sleep. There's a lot of research out now showing how very, very important good sleep is and how it affects all the other systems in the body. Many of our early intervention clients, again, have general developmental delays, are not diagnosed. Sometimes they're diagnosed with general developmental delays. Sometimes they're not diagnosed at all. And that's fine. We don't always need to see a diagnosis in order to work with a child if we know that they have delays. Sometimes the diagnosis is that they're slow to achieve their developmental milestones. And if you recall from the PowerPoint early on motor development, slow achievement of motor milestones does not bode well for the future, means that a child is more likely to have ongoing gross motor delays as they get older. Torticollis is a congenital shortening of the sternocleidomastoid muscle. So if you can take a second and kind of locate the sternocleidomastoid, that goes from behind your ear on the mastoid bone, and also from your clavicle, and it comes at an angle down to your sternum. So it's that one where sometimes you crick your neck and you get this really sharp, tight pain in your neck. That's a torticollis. Some children are born with torticollis, with a congenital shortening of that muscle. About 50% of the time, the children do quite well. You give them positioning and exercises and things to strengthen and improve the turning and the side bending. It's lateral flexion and rotation that they are losing. You give them positioning, the parents positioning things and exercises to do, and the kids do quite well. About half the time, the kids go on to have very severe developmental disabilities. So it's not in and of itself an indication that there is going to be a problem, but about half the kids with torticollis do end up with severe developmental disabilities. So what we see when we have a new client that's come to us is we generally see that they're not gaining their developmental milestones in the way that they're supposed to. We see that they have trouble with social skills and behaviors. One of the things we see first is not walking and not talking. This is what parents usually want to see in kids from birth to 3. I want my child walking. I want my child talking. There's been some research a while back now on late talkers, on children who developmentally are doing quite well, but they are slow to begin to talk. And they have found that that's not always a sign of any disability whatsoever. Some children are just slow to talk for a variety of reasons. So we might see those children. Sometimes there's difficulty taking care of the child. That's the feeding, sleeping, and dressing issues that they might have. One of the things to understand when working with young children is that they don't develop all their skill areas at the same time. So a young child might get to a certain point in talking and then kind of hold on to that level and start working on walking. And then once they get walking down pat, then they'll go back and start working on the talking. So children develop one area at a time and kind of hold with the other areas while they're learning a brand new one, especially something big like walking or talking. So we need to remember that. One of the reasons it's important to understand that's how development works is in part to understand that that's what gives the wide variety to young development. That's one of the reasons why there's such a huge range of normal, because one child might have gotten to one-word utterances and then decide it's time to learn how to walk, and another child might get up to 2- and 3-word utterances before they decide it's time to learn to walk. So that's just a big range of normal. The other reason to understand that variety in normal development is to understand that young children never go backwards in their developmental skills. That's always a time for a red flag and a serious concern. Young children may stop one area while they go forward in another area, but they're not going to go backwards. They're not going to lose skills that they already had. So anytime a young child loses skills or stops doing something they were doing, like they used to walk but now they're only crawling, or they used to speak in sentences and now they don't speak, or they just use one-word utterances, those are always times for concern and times to refer the family back to their primary care physician to find out what's going on. It's not usually good. The occupations of a young child obviously play. They learn through play. They learn through imitation. One of the biggest goals of a young child motorically is to beat gravity, is to get up against gravity. And some say 8-year-old boys are still trying to beat gravity. But that's what they want to do. They want to get up and vertical and move through space. They want to move from relying on and depending on and being focused on themselves and their close family to being reliant on social groups for their social emotional development. And overall, of course, they want to understand the way the world works. So again, we talked about tone is slow to express itself and can take up to 18 months until we know what that abnormal tone is going to look like. That's especially true, as I said before, of high muscle tone. What the next one says is that you may find other areas to focus on when motor is difficult, is that if a child is having some issues with, for example, moving, then find other things that they do well and focus on those things. So you might focus on their speech or on their play skills or some other thing when they're getting frustrated with something. And you're going to come back to the difficult areas. You're not going to drop them, but sometimes it helps to shift and then come back again. Another thing to understand is that children with high muscle tone, they did some research on adults with high muscle tone with cerebral palsy, and they found a significant number, something over 70%, have chronic pain associated with that muscle tone. So in children, the way that shows up is in sleep issues, because children are marvelously distractible. You can show them shiny bits and play silly games and goof them around, and they will not notice that they're in pain. But as soon as the lights are out and they're alone in the dark trying to go to sleep, that's when they're going to notice the pain is there. So children with high tone that have pain or that have sleep issues are likely to be having pain, and that's important to get that addressed. When it comes to feeding issues, if someone has low muscle tone in other parts of their body, they probably have low muscle tone orally. If they have high muscle tone elsewhere in their body, they probably have high muscle tone in their mouth for feeding. So we want to know that, remember that tone is tone, and we're going to run into feeding and speech issues when children have tone abnormalities. So we're going to talk a little bit more about autism in a different slide presentation, but for this one, we want to know that the research shows that the diagnosis of autism is stable after age 2. Although currently there is a lot of research going on looking for early indicators of autism. None of this is really robust yet. There's still a lot of people thinking about this topic and doing some preliminary research. But that's the way things are headed at this point, is that researchers are looking at earlier and earlier signs of autism so that it's possible to intervene earlier. There may be symptoms earlier or not. What I mean here is that some children have autism who always were kind of off, right? They didn't have great eye contact. They didn't have great gross motor skills. They didn't have great speech skills. Nothing really came along as it was supposed to. And then right around age 2, they get diagnosed with autism. Other children can be developing quite typically and be achieving their milestones more or less right when they're supposed to. And then at some point things fall apart and they no longer can function, and then they're diagnosed. These may or may not be different kinds of autism. I think there's some decent evidence to show that they might be, and there's quite a few researchers who are working on what does this mean, what are the kinds of autistic-like symptoms out there, and do they comprise actually different disorders or constellations of the same disorder. There's a lot of research going on around that right now. Children with autistic-like behaviors certainly have language and behavior concerns. They are all at risk for gross and fine motor delays. And one of the things that we have to take a look at is the distinction between behavior and sensory processing issues in autism. Significant sensory processing issues, once treated with good sensory input, resolve fairly quickly, get better quickly. Autism is pervasive. It does not get better quickly. So when you start to treat a child that seems to be diagnosed or seems to have autism, and you're treating their sensory symptoms and they're really improving quite rapidly, you have to take a step back and say, well, wait a minute, this child probably isn't autistic. They probably have sensory processing issues, but it is hard to differentiate until you start trying to address the issues. The same with behavior. Kids on the autism spectrum exhibit all kinds of behaviors that are not typical. There are children who have behavior problems that do not have autism, but they have behavior problems. There are also children with significant intellectual disabilities. And when you think about significant intellectual disabilities and kids with autism, they can kind of look a lot alike. So it's difficult to discriminate between those, but very important to try.